Thank you. All right. So I'd like to welcome everybody to Pediatric Grand Rounds. Before we get started here, there are a couple of housekeeping things to take care of. There's a sheet of paper on everybody's table. Looks like this. It's got the ETSU letterhead on top. This paper contains information on setting up a profile for the new CME system. If you follow these instructions, it sounds like things are going to be a little more straightforward in the future. We're going to scan a QR code. So if everybody could follow these instructions and set up a profile online, I think it will ease this process. But currently we are still using the previous system, so there's also a horizontal sheet of paper, landscape sheet of paper, that has the phone number to call and event ID number. If you could please call this number and log in, it helps justify lunch and will help you keep track of your credits throughout the year and help us track attendance. So that would be much appreciated. So today it's my pleasure to introduce Dr. Melody Miller, who's going to be giving us a talk on SIDS and safe sleep. Dr. Miller is from Wisconsin, for those of you who don't know. She attended University of Wisconsin for undergrad and the Kirksville College of Osteopathic Medicine for medical school, and she came down here to the mountains to join us. She's done numerous community advocacy activities, and she wants to carry that passion forward into practice in community pediatrics here in a few months. So it's my pleasure. Let's welcome Dr. Melody Miller.
Thank you. Hi everyone, I'm Dr. Melody Miller, and today's topic is SIDS and safe sleep. Today I'll be discussing preventative strategies, educational tools, and facts for healthcare providers and caregivers. I have nothing to disclose. Looking at what we should talk about today, I'd like to define sudden infant death syndrome and sudden unexpected infant death syndrome. Also, I will talk about the incidence and epidemiology of these two. I will talk about risk factors for them and research pertaining to each risk factor. Also talk about current theories on the pathogenesis of SIDS, current AAP guidelines and recommendations for safe sleep, and also describe current U.S. sleeping statistics, and elaborate on a variety of educational tools for promoting safe sleep, and discuss several campaigns throughout the world, the U.S. and locally regarding safe sleep. So anyone who knows me knows that I love babies, and so here's some really cute babies. Throughout my years in residency, I have talked a lot about safe sleep with families, as well as many other anticipatory guidance. And it seems like there was a lot of confusion with mothers, grandmothers, great-grandmothers over what really should be done to keep an infant safe, especially during sleep. A lot of families were surprised at when I told them that they need to place the baby on their back for sleep. And so I thought it would be a good topic to discuss. So what is SIDS and SUID? Before this presentation, I had never really heard of SUID. It's basically the sudden and unexpected death of a previously healthy baby less than 1 year old, in which the cause was not obvious before investigation. So it's a little bit broader of a diagnosis, and it does include SIDS, unknown causes, and accidental suffocation and strangulation. Sleep-related causes. Looking at what SIDS is, it is the sudden death of an infant under 1 year of age, which remains unexplained after a thorough case investigation, including performance of a complete autopsy, examination of the death scene, and review of the clinical history. So it goes into a little bit more of a focus rather than SUID. It is important to bring up the difference between these two definitions because autopsy reports and coroners have changed the definition and changed the terminology on what exactly is the cause of death. So unknown is becoming a little bit more prevalent rather than SIDS. There's also a very large stigma behind SIDS, so SUID is more of the term that we use now. looking a little bit more into SUID, there are over 3,500 sleep-related deaths each year in the US alone. As I told you, it's broken down into 3 different categories, as you can see in the pie chart. Sudden infant death syndrome is the large majority of SUID, encompassing 43%. And next is unknown causes, and then next is accidental suffocation and strangulation. So there's a lot of different diseases and processes that can mimic SIDS and look like SIDS when a baby is found. Sepsis, as we know, can look a little bit like SIDS, a very unexpected, rapid inflammatory response in babies. Asphyxiation, metabolic decompensation, if a baby is hyperthermic for whatever reason. Poisonings or exposures to different chemicals can cause a baby to pass away. Also, inborn errors of metabolism. A lot of times we don't get that newborn screen back right away, and so if something happens, it's unknown to us, but it could have been an inborn error of metabolism. Also, sickle cell. If we don't know that the baby has sickle cell, they could have gone into a crisis in the middle of the night. Also, congenital heart disease, myocarditis. We know that hits kids really hard and unexpectedly. It can hit babies too. Pneumonia, bronchiolitis, aspiration and airway obstruction, enterocolitis, hepatitis, pancreatitis, and then cystic fibrosis may be undiagnosed at the time. Also, congenital adrenal hyperplasia, encephalitis. We know babies can get infections in their brain pretty easily. Also, trauma or child abuse may present, and it may not be apparent right away based on the history that's given by the caregivers. And another one is arteriovenous malformations with bleed. Those are often undiagnosed due to lack of imaging at infant age. So we'll look into a little bit more of epidemiology, looking at the trends of SUID in the US over time. You can see by the yellow line up here, since 1990, the rate of SUID has declined quite a bit. However, since around 2004, 2005, it's kind of plateaued. And also looking at the definitions and the breakdown of those 3 areas that SUID encompasses, you can see that SIDS has declined along with the SUID. However, if you look at unknown causes and then the accidental suffocation and strangulation in bed, that has actually gone a little bit up in most recent years. It's questionable whether that has gone up due to that being the cause or the decline in the SIDS diagnosis given on autopsy reports, which is why the term SUID is favored over SIDS. So I was wondering, how does SIDS relate to overall infant mortality? And it actually plays a significant role. So looking at US infant mortality in 2015, there were 5.9 deaths per 1,000 live births. That encompasses 23,000 infants per year. That's a pretty large number. And looking at the causes, the top 5 causes, number 1 is from birth defects. Number 2 is from preterm births or low birth weight. And then number 3, there's our SIDS. So it's actually a pretty high cause of death for infants. And it is something that we really should be considering as a population health problem. For other benefits, the 4th cause of death is maternal pregnancy complications, and number 5 is injuries. Looking at the map of the US, I thought I would show that there's great variation based on region that you live in the country, based on what the infant mortality is in general. The lighter colors, the light tan and the light green colors, show a lower death rate, and then the darker colors, the navy and the dark blue, show a higher rate of death in general infant mortality. And as you can see, the southeast where we are actually struggles in this topic. So it's definitely an area that we can look at. Looking at the states, kind of breaking them down, the top 5 highest states for infant mortality is Alabama, Mississippi, Arkansas, Louisiana, and Delaware. The lower states are New Hampshire, Massachusetts, New Jersey, California, and Washington. So kind of like we saw on the map, Southeast struggles a little bit more in that, and then the Northeast and California, basically the Northeast and the West Coast, do a little bit better for infant mortality. Just to show a little bit about the dire need for this type of education, Tennessee is the 8th highest rate of infant mortality in the country, and we have 7.4 deaths per 1,000 live births. Looking at the epidemiology of SIDS, the overall risk in the U.S. is less than 1 per 1,000 live births, which sounds like a low number, but when it's your child, it doesn't feel like it. And then as the definition, age is less than 12 months. 90% of these occur in the first 6 months of life, and the peak age is between 2 and 4 months of life. The median age is around 11 weeks. There is a predominance in the male gender of 3 to 1 or 3 to 2. Also, there are racial disparities, which I'll address in the next slide. I found it interesting that 15 to 20% of SIDS cases occur in child care settings, which also addresses a concern that we need to educate everyone that takes care of the children. Looking at risk factors for SIDS, over 95% of the cases have at least one risk factor, and a lot of times this risk factor is modifiable. 88% of cases have 2 or more risk factors. So let's look a little bit more of the racial disparities. This is a graph that shows 5 different ethnicities or races, and as you can see, the left column is American Indian and Alaskan Natives. The second column is non-Hispanic Black, and then from there it's non-Hispanic White, Hispanics, and Asian Pacific Islanders. As you can see, the left 2 columns have over double the column size or infant mortality of SUID compared to the 3 other columns. So that places the American Indian and Alaskan Natives, as well as the non-Hispanic Blacks, at a higher risk for SUID. Also, you can see that the breakdown between the 3 types of SUID are pretty proportional in all races. Looking at risk factors for SIDS, there are several. So I broke it down into infant factors and maternal or antenatal factors. As far as infant factors, low birth weight, less than 2,500 grams, is associated with a 5 times increased risk of SIDS. Also SGA. There's racial differences, which we just talked about. The male gender is at a more risk than female gender. Also colder climates. There is a double the risk in a colder month than warmer months. So interestingly, the winter months, you do have an elevated risk for SIDS than the warmer months for whatever reason. Also, looking at prematurity, they're at 3 to 4 times the increased risk. And if you look at if you have an infant who's low birth weight and they are prone or sideline, you're looking at 15 to 24 times the increased risk. So there's that prone sleeping that is very dangerous. Sleep environment places them at increased risk, including pillows, bed sharing, and loose bedding. We'll talk a little bit more about that. Also recent GI illness, overheating for whatever reason, and breastfeeding is actually a protective effect. And then if you are a sibling of a SIDS victim, you do have elevated risk of 5 to 6 times. However, that risk is still less than 1%. So if a mom comes to you and is really concerned because she had a previous child pass away, the risk of another child having SIDS is still very low. And then twins, for some reason, are at an increased risk. Looking at maternal and antenatal factors, maternal smoking increases the risk by 2 to 4 times, and that even includes prenatal exposure. If someone stops smoking after the baby's born, the baby is still at an increased risk, which I found interesting. Also, illicit drug use and alcohol use increases the risk. They found that binge drinking in the first trimester is dangerous and also increases the risk. And for some reason, it also increases the risk, especially in the Native American population. Young mothers less than 20, also unmarried, and mothers who do not have a high school degree have an elevated risk for this. Also, babies who are born from pregnancies where there was late or no prenatal care are at increased risk. And if there was poor gestational weight gain, if the mom had anemia during pregnancy, if she had a UTI or STI, also if there was a short interpregnancy interval, if there was placenta previa or abruption or premature rupture of membranes, or also if the mom had elevated alpha fetoprotein. Looking a little bit more into the sleep environment, it's been shown that soft sleeping surfaces and bedding increase the risk by 5 times. This includes sofa chairs, recliners, air mattresses, and sheepskin bedding. You can see the picture of the baby on the sheepskin. If the baby was placed down prone, some of the fuzzies could cause airway obstruction. Also, soft bedding along with prone position puts an infant at 21 times the risk for SIDS. Looking at loose bedding, which is 5 times the risk, that's quilts, blankets, pillows, stuffed toys, etc. Those are dangerous and place the infant at a 5 times increased risk. Also, crib bumper pads is one of the key discussions that is being looked at now, just because, as you could see, there is an increase in rate of suffocations when we looked at those 3 different types of SUID, and that is one that is increasing despite recommendations against the use for crib bumper pads. Looking at bed sharing, that increases by 2.8 to 15 times the risk depending on the study that you look at, and it is also based on other risk factors. So if a baby's going to be sleeping with you, you probably have other pillows, other blankets, etc. And this risk, if someone is to bed share with the baby's at a higher risk if they're less than 3 months of age, and if the mom smokes, even if she doesn't smoke in bed or in the bedroom. Twins and multiples, I thought these were cute little bunnies. The recommendations currently are that twins sleep in separate beds or separate sleeping spaces, although some people would prefer that they have their babies together for whatever reason. It's best that they are kept in their own sleep areas. Car seats. This is an important topic because there is a small increase in SIDS risk if a baby is sleeping in a car seat. The theory is that it potentiates reflux and may reduce oxygenation. I think this is based on positioning, their low truncal tone, and their head is kind of angled downward a little bit. However, the benefit during travel outweighs the risk for SIDS. So the recommendation is that if you're traveling with a baby and they fall asleep, once you get to your destination, you place the baby safely in their own safe sleep environment and safe sleep location. Looking at sling carriers, a lot of moms use these to carry around their baby so they can get some things done. Just as a report, there has been some sleep-related deaths associated with sling carriers. So we can't recommend those at this time. Also, looking at overheating, Overheating is a risk if the baby is wearing 2 or more layers of clothing. That's associated with a 6 times increased risk. Also, swaddling, there's really unclear evidence to associate it with SIDS and sleep-related deaths. But if the baby is swaddled and they become prone, or if they're placed prone, or if they're placed side-lying position, there's likely a 2 times increased risk. Factors not correlated with SIDS, these were surprising, so I thought I would include them. Infant vital signs or minor abnormalities in them. Also apnea of prematurity or clinical history of some episodic apnea is not correlated with SIDS. Also recurrent cyanosis is not. There was a study that looked at SIDS victims, and they did a questionnaire for whether the parents recognized cyanosis in the prior months beforehand, and there was no significant correlation between the parents of the kids who passed away from SIDS and the control group. Also, apparent life-threatening events or brief resolved unexplained events or BRUIs are not correlated with SIDS. So make sure that if we have infants admitted to the hospital for BRUIs, we do not, we do tell them that it is not correlated with the increased risk of SIDS, which is, a lot of parents are concerned about that. Also, immunizations are not correlated with SIDS. There may actually even be a protective effect of them, but the research is still out. Looking at CR monitors, they are not helpful in protecting or changing the risk of SIDS. So let's talk about protective factors against SIDS. So what can we do to help? Room sharing. In one New Zealand study, there was an 80% reduced risk of SIDS when the patient was supine and in the same room as the adult, which is really cool. And that also is part of the updated guidelines from 2016 in the AAP, which I will talk about. Also, breastfeeding, either exclusive or partial breastfeeding, is a protective effect. It was found in an October study just last year that any type of breastfeeding for at least 2 months cut the risk for SIDS by 50%. So we'll let that sink in. Also, this risk was independent, or this protective effect was independent of other risk factors, which is really, really cool. Also, the protective effect of this increases with the greater duration of breastfeeding, the exclusivity of breastfeeding, and so forth. Looking at pacifier use, the mechanism of this is very unclear. However, studies have shown a 29 to 46% decreased risk with using a pacifier. There's been some theories about fan usage in the rooms that babies are sleeping. There was one population-based study in California that showed a reduced risk, but it wasn't a very good study, and so the research is still out on fan use. Immunizations, there was some type of rumor going around about Dtap causing SIDS, but that's been definitely ruled out. And actually, 3 case control studies have shown between a 45 and a 54% reduced risk if a baby was properly immunized. But we definitely need more research in that area too. So what causes SIDS or SUID? There's a bunch of pathogenesis theories. Most likely it's polygenic and multifactorial. One of the main used models is a triple risk model, which includes an underlying abnormality, such as like a genetic condition or a brainstem abnormality that predisposes infants for this. Also, there's a triggering event, either an airflow obstruction or maternal smoking, etc. And then the third thing they need is to be vulnerable stage of their development, either with their CNS or their immune system. So these 3 things kind of all combine together to be very detrimental for the infant. Other theories can be tied to either one of those 3 triple risks that we've talked about. There's been issues about failure of arousal mechanisms, including abnormalities of the arcuate nucleus in the brainstem, causing abnormal arousal, or abnormal cardiorespiratory control, and abnormal cardiovascular control. Also, there's been some theories about serotonergic signaling, so alterations in serotonin receptor abnormalities or serotonin transporter proteins, which can cause increased transport and decreased serotonin at the synapses, which somehow makes a baby more prone to SIDS. Also, a baby could have a sodium channel gene mutation, SCN5A, which cause prolonged QT interval that could predispose an infant. Also, gene alterations affecting the autonomic nervous system have been proposed as possible theories. So, now that we talked a little bit about risk factors and epidemiology, let's talk about the current AAP guidelines that were just updated in 2016. The AAP really would like to recommend back to sleep for every sleep, which means you place the infant completely supine for every sleep until they're 1 year old. Also avoid side sleeping and prone sleeping. Prone sleeping, however, is recommended for very rare cases, such as an airway disorder where the risk of death from reflux is greater than the risk of SIDS. That's something like a type 3 or type 4 laryngeal cleft without anti-reflux surgery. Again, that's very rare. And then they do support tummy time or awake and observed tummy time, placing an infant prone then. The AAP also notes and wanted to put this little hint in there that supine sleeping does not increase the risk for aspiration or choking, even in infants with reflux. There is no evidence or insignificant evidence that supine positioning increases aspiration in infants with NG or OG tubes. Also, elevating the head of the infant's crib does not reduce reflux, and actually they found that infants can sometimes slide to the bottom of the crib and then their airway can be compromised. Also, the AAP recommends that once the infant is rolling, the infant can remain in that position. So the parents don't have to keep waking up every 10 minutes to put them back on their back. You want to use a firm sleep surface for babies, which basically is defined as a surface that holds its shape and does not indent when the infant's head is placed down. You also want to have a snugly fitted mattress in the crib that is safely approved, or a crib that is safety approved by the Consumer Product Safety Commission. And you do want to have tightly fitted sheets. We'd like you to avoid memory foam mattresses, mattress toppers, cribs with missing hardware, or any type of home repaired cribs and whatnot, and also mattresses that are not designed for that specific crib. Bedside sleepers may be considered, but there's not enough research on them to say anything else on them. And then, as I already discussed, we don't want any extra things in the crib, such as stuffed toys, pillows, quilts, comforters. We don't want babies sleeping on any regular beds with their parents. Also make sure that the infant's sleep area is free of hazards, so no window strings, no electrical outlets, anything like that that could harm the baby. And then we don't recommend routine sleeping in car seats, strollers, swings, infant carriers, slings, etc. And then you do want to avoid couches, sofas, armchairs, and because there's an extraordinarily increased risk for SIDS there. Of note, if a mother was to fall asleep or a father was to fall asleep with their baby, it would be better for that to happen in a bed rather than a sofa or recliner due to this high risk. Also, just to note, as far as a sling use, if the mother does want to use a sling, it's important to make sure that the head is up and away from the covering. You don't want to have the head covered by the sling. Breastfeeding is recommended. Obviously, we always approve breastfeeding unless otherwise contraindicated. Mothers should breastfeed exclusively for at least 6 months, unless contraindicated. This protective effect increases with exclusivity, as I already said, and any type of breastfeeding is better than no breastfeeding. Infants should sleep in their parents' room close to the parents' bed, but on a separate surface designed for infants, ideally for the first year of life, but at least for the first 6 months. This could reduce the SIDS risk by 50%. Also, it reduces sleep-related deaths. Placing the baby in a crib, a portable crib, a play yard, or a bassinet in the parent's room is very important. Also, the infant should be in view and close by to facilitate monitoring, feeding, and soothing. I think the reason that this may help is because then the parents, they wake up in the middle of the night, they're exhausted, get out of bed, and the baby's right there. So you can feed the baby or do whatever, change the baby, and then place the baby back in their bed, and then you go back to your own bed. And it's important to note, obviously, it's good to snuggle with your baby, but if you want to fall back asleep, the baby should be placed in their own bed. Bed sharing is most dangerous in infants who are less than 4 months of age. Also, in infants who have been exposed either prenatally or environmentally to tobacco. Also, if they're sleeping with someone that is impaired by medication or other substances. Also, if it is a non-parental caregiver, that increases their risk. Or if there's soft surfaces or soft bedding accessories. Keeping soft objects and loose bedding away from the infant's sleep area to reduce the risk of SIDS, suffocation, entrapment, and strangulation is important. This includes pillows, stuffed toys, comforters, this elephant. Also, you do want to use tightly fitted sheets, and the AAP does say that wearable blankets are preferred over other coverings because you don't want to have extra blankets hanging around and then covering the baby's face. That can be dangerous. And then, once again, avoid using bumper pads on the cribs. You should consider offering a pacifier at nap time and at bedtime. This is a protective effect against SIDS for unclear mechanisms, as we already talked about. There's no need to wake up every 10 minutes and put the passy back in. Just starting the infant out when they fall asleep is fine. Also, you don't want to have a passy that has an attached stuffed animal or an attached cord that clips onto their clothes, just because that increases their risk for strangulation and other things. And then you do want to hold off on pacifier use until breastfeeding is firmly established in those first few weeks. Avoid smoke exposure during pregnancy and after birth. These are major risk factors for SIDS. Much higher risk if the infant bed shares with the adult, even if the adult smokes and doesn't smoke in the bedroom, as we already talked about. And then it is important to encourage our families to have a strict smoke-free zone where infants and non-smokers can be either in the car or in the house, etc., just so they don't have that exposure. You want to avoid alcohol and illicit drug use during pregnancy and after birth. And that's associated with a particularly high risk of SIDS. You want to avoid overheating and head covering in infants. We already talked about this. There isn't any guidelines on specific room temperatures, but the rule of thumb is to not dress an infant in more than one layer, more than what an average adult would wear comfortably. And then you do want to evaluate the infant periodically to see if they're getting overheated, if they're sweating, or if their chest feels really warm to touch, and make sure they're not getting overheated. And then, as we talked about, you want to avoid overbundling and avoid getting anything that could cover the baby's face. And we already talked about fans. Pregnant women should obtain regular prenatal care, follow their prenatal guidelines, etc. Infants should be immunized in accordance with recommendations from the AAP and the CDC. There's no causal relationship between SIDS and immunizations, and like I said before, there may be even a protective effect. You want to avoid the use of commercial devices that are inconsistent with safe sleep. Be wary of any devices that claim to reduce SIDS risk. There are some devices for placing in infants' beds. There's not enough evidence on those to say that they're good or bad, but right now we should probably hold off on them. Also, there's some crib mattresses that say they increase CO2 dispersion. It's unclear of any disadvantages from that, so evidence is not out there yet for those. Also, we do not recommend using home CR monitors as a strategy to reduce the risk of SIDS. It's not been shown that they do reduce the risk, and even CR monitoring before hospital discharge has not been shown to predict SIDS risk. We do recommend supervised awake tummy time for improving development and minimizing positional plagiocephaly. There are separate guidelines on plagiocephaly, and we know that supervised tummy time while the infants are awake helps with development of upper shoulder girdle strength. And then we do want to avoid excessive car seat use for sleeping regularly. One thing that we can advise for parents to reduce positional plagiocephaly is to place the infant in their crib, either with their head on the right and then switch to the left sometimes, just to switch it up a little bit. There's no evidence to recommend swaddling as a strategy to reduce the risk of SIDS. So basically, if you do swaddle, you want to make sure the baby isn't going to roll over and become prone, because that would increase their risk for SIDS. You do want to make sure that it's snug around the chest. The arms can be in or out, depending. And then you want to make sure it's looser around the hips and the knees to avoid exacerbations of any possible hip dysplasia. And then you do want to stop swaddling once the infant shows signs for rolling over, just in case you don't want to hold in their body and their movements and their extremity use if they're going to roll over and become prone. Healthcare professionals and staff in newborn nurseries and NICUs, as well as child care providers, should endorse and model the SIDS risk reduction recommendations starting at birth. So this modeling should start as soon as the infant is medically stable or well before discharge. We should be educating physicians, staff, and other healthcare providers on safe sleep. And also we should be screening for and recommending safe sleep practices at every infant visit at less than 1 year. This is important if we see indicators that they do not have a safe sleep space. We should provide them with information on low-cost or free cribs or play yards to help with families so that they can get a safe place for their baby to sleep. Also, hospital policy should be consistent with these safe sleep recommendations, and state regulatory agencies should require safe sleep education for all child care providers, which is important, just like, as I said, the 15 to 20% of SIDS occur at child care facilities. The media and manufacturers should follow safe sleep guidelines in their messaging and advertising. This is a big one. It was actually very difficult to find infants sleeping safely on Google Images, but here's a few examples. The AAP plans to continue the Safe to Sleep campaign, focusing on ways to reduce the risk of all sleep-related infant deaths, including SIDS, suffocation, and also other unintentional deaths. Pediatricians and other PCPs should actively participate in this campaign. We should try to overcome barriers for behavior change. Also, we should focus specifically on the American Indian, Alaskan Native, and Black populations that are at the highest risk when looking at SIDS and safe sleep. Also, strategies to increase breastfeeding and reduce bed sharing are important, highlighting risk factors that increase the risk for SIDS. Also, we should be introducing safe sleep recommendations prior to pregnancy. So the AAP says ideally introduce these ideas and recommendations in high school to males and females and anyone that could possibly be caregiving for babies. And then as they get older and want to start their own family, they'll have some basic knowledge. Also, reissuing of safe sleep messages should be done every 5 years, is what the AAP said they're going to help us with. We'd like to continue research and surveillance of SIDS risk factors, causes, and pathophysiology of SIDS. Also, the ultimate goal is to eliminate these deaths altogether. We'd like to improve research, improve safety, improve monitoring. So in having CDC standardized protocols for death scene investigations, education for first responders, for law enforcement, and for medical examiners and coroners, and improving widespread surveillance of SIDS and SUID. So now that we looked at the guidelines, let's see what we can do about it and how we're doing so far. First, let's look at the barriers working against us. There are changing AAP guidelines. So when I was born, before 1992, they were recommending side sleep positions. In 1992, they changed those guidelines to say, sleep on your back. Also, inadequate educational delivery or inaccurate educational delivery has been proposed as issues. Also, cultural practices. So if grandma and grandpa did this all their life, they may be more prone to doing that for their children too. Also, poor education for healthcare providers. Also, poor hospital and daycare modeling, as we've talked about. Also, lack of emphasis on safe sleep in the mainstream media. And parental beliefs of immunity to SIDS. So everyone thinks it's not going to happen to me, but it can. So how safe are infants sleeping? The CDC analyzed data from the Pregnancy Risk Assessment Monitoring System, or PRAMS, which was a database from 2009 to 2015. It was a questionnaire for mothers with 2 to 6 month old infants. And it found that 21% were not sleeping supine. The lowest was in Wisconsin, 12%. The highest was in Louisiana at 33%. Also, the non-supine sleep was higher in mothers who were younger, less than 25 years of age, if they did not complete high school, and if they were WIC participants. Looking at bed sharing, mothers reported they often or always bed shared at 24% of the US. Also, 37% rarely or sometimes did bed sharing. In West Virginia, it was 49%, and in Alaska, it was 78%. So that's a pretty huge number. And it was higher in American Indians, Alaskan Natives, non-Hispanic Blacks, and Asians and Pacific Islanders for bed sharing. Looking at SOF's bedding use, it was used in 38%, the lowest in Illinois, and the highest in New York City. Bumper pads were the #1 cause, second to plush thick blankets, pillows, infant positioners, and stuffed toys. And this was higher in Asian and Pacific Islanders, Hispanics, mothers who were younger, less than 25, had not completed high school, as well as WIC participants and mothers who did not breastfeed longer than 8 weeks. So I think we can do better. Looking at more of a chart form, you can see the 3 columns are not placing the baby back on the back for sleep, the bed sharing, and soft bedding. We've already talked about some of the ethnicity differences. I wanted to point out, however, that looking at the 19 or less age for mothers, across all columns, there was a higher rate. And that was significant for all 3 of these columns and all age groups. So these young moms are really at risk. So how are we doing at educating parents? There was a study called the Study of Attitudes and Factors Affecting Infant Care, or the SAFE survey. This survey questioned more than 3,000 mothers of infants 2 to 6 months of age, and it looked at sleep practices and what affected maternal decision making. It showed that intention and usual practice of sleep positioning are strongly based on social norms, and so whatever, parenting's very hard, so you think about what's really expected, what should I be doing based on what is my community doing, what are people around me doing. Also, attitudes affected it, so feelings of whether the infant was better off, either prone or side lying, or wherever they think the baby would have less choking, or they felt the baby would be safer. Also perceived control over it. Some moms thought they had no control and it was up to the baby where they would place them, whether the baby would cry in one position or whatnot. If mothers felt it wasn't up to their control, they were at higher risk. Also, they asked what kind of advice doctors were giving them, and the mothers reported 55% received apparent or appropriate advice, 25% reported receiving incorrect advice, and 20% did not receive any advice on safe sleep. So we can do better here too. How are our hospitals doing? Massachusetts Department of Public Health made a policy for safe sleep. As part of this policy, they made recommendations for families based on the AAP guidelines. They also implemented changes to the state child serving agencies and state child fatality review team. They also did a QI project called Improving Safe Sleep Practices in High-Risk Infants. This was done correlated with the Massachusetts Perinatal Neonatology Quality Improvement Network. This included 9 level 3 NICUs in Massachusetts, and what they did is they surveyed, or they figured out how well the current hospital practices were doing as far as safe sleep guidelines and following those guidelines. And then they did progress reports, webinars, weekly crib audits. So they walked around and they said, check this, check that, check that. And they looked at if there was supine positioning, if the crib was flat with no incline, if there wasn't any positioning devices, if there weren't any soft objects, etc. And they also did statewide summits, which were biannual. The results of this showed safe sleep compliance increased from 48% to 76% in a matter of about a year and a half. As you can see the trend upward from kind of a lower numbers all the way upward to that 76%. So a little bit of education can go a long way. How can we better educate our parents and families? So I read an article that showed various strategies that have been used in the past and pros and cons to each of these. I'm not advocating for any of these, however, but just wanted to introduce some ideas of what has been used in the past. Obviously, physician or provider advice is given a lot. Mothers who received proper safe sleep advice were less likely to report placing their infant prone or on their side. Also, if they received advice against the safe sleep guidelines, were more likely to report placing their infants prone or on their side. So in general, they did listen to what was recommended to them from providers. Also, some campaigns have focused on doing little sound bites, so back to sleep, using that back to sleep. That's all you need to know. It's been shown that we do need to promote realization that this can happen to your baby too, because otherwise people will kind of blow off that idea and just say, well, that's not going to happen to my child. And also, you do have to recognize that parents may have questions, so just saying back to sleep may not answer all their questions. Another group did a question and answer session, including a 15-minute Q&A session, which improved sleep positioning from 45 to 75% compliance and reduced bed sharing from 44 to 16%. And these effects were even stable after 6 months after this intervention. Videos have been used in the past. In Baltimore, Maryland, they did a video called Be More for Healthy Babies campaign in 2010. They showed a video called Sleep Safe, A Lone Back Crib, No Exceptions. It showed parents of children who had passed away from SIDS and also had interjections from healthcare professionals. They showed these videos at 7 birth hospitals, WIC offices, city detention centers, Department of Social Service offices, and jury duty locations. And they did, preliminarily results did show that there was reduced sleep-related deaths by 46%. There's also been some scary messaging tactics out there. The Milwaukee, Wisconsin Department of Health used an Imagery Campaign in 2010. They showed either billboards or ads that showed one of them was an image of an adult bed with a tombstone for the headboard, and the saying, far too many babies, for far too many babies this last year, this was their final resting place. So that kind of hit home for some people. Also, they showed an infant resting on an adult bed next to a knife, saying your baby sleeping with you can be just as dangerous. It's been very controversial campaign, as you can see, and there's been unknown significance or effectiveness. However, of note, requests for cribs at the Department of Health in Milwaukee increased from 671 in 2009 before the campaign to 2,043 in 2011 after the campaign. Looking back at the rates of SUID and SIDS over time, and I wanted to talk about the impacts that some nationwide campaigns have had. So in 1990, the SUID rate was 154 deaths per 100,000 live births, which declined significantly after the AAP released safe sleep recommendations in 1992, which is marked by the first arrow. The second arrow is when the Back to Sleep campaign was initiated, which I'll talk about next. And also the SUID investigative reporting form was released in 1996, which is the third arrow. And it's been theorized that these things have caused these declines in the SUID rate. But as you can see, there's plateaus in the SUID rate, which means we really need to keep working on this. In 2015, there were 92.6 deaths per 100,000 live births, which is a significant decrease from the 154 before in 1990. Looking at different campaigns, the Back to Sleep campaign is a large one. Some of the residents may recognize this little poster that we have similar posters in our hospital. This Back to Sleep campaign was a collaborative effort starting in 1994 by the National Institute of Child Health and Development, the AAP, and several other organizations. It encouraged parents to place infants on their backs for sleep. They did a broad dispersal of informative materials to AAP members, the OBGYNs going to the ACOG members. Also, they went to all U.S. hospitals and newborn nurseries and to WIC offices. So they were really spreading out all of this information. And they found that from 1993 to 2010, supine sleep positioning increased from 17 to 73%, so quite a big increase. To build on this campaign, they changed the name to Safe to Sleep campaign with the goal to educate all types of caregivers on safe sleep in all communities. So they now do some type of campaigns that help with the Healthy Native Babies Project to help with Native Americans and Alaskan Natives. Also SIDS Sundays, which have SIDS discussions at churches, Text for Baby programs, SIDS reduction curriculum for nurses, etc. Another campaign is Cribs for Kids in 1998. This provides a free or reduced price portable crib to low-income families without a crib. This also provides some fitted sheets, some blanket, pacifier, and educational materials, including a brochure, a refrigerator magnet, a DVD, and then a board book. The results of this showed that 38% of infants would have slept in an adult bed if not provided with a crib. Other campaigns include Bedtime Basics for Babies. They provide a free crib and educational materials in the 3 states listed there. Also, the HALO project, which is an in-hospital sleep sack program in the US and Canada. They give a swaddle wearable blanket to all NICUs and nurseries participating. There's Charlie's Kids, which provides a board book, and that is in multiple languages and in 33 different states. There's the 1,000 Grandmothers Project, which is an educational aims towards elders, especially in the American Indian tribes, looking at trying to break down some of the cultural barriers and help educate all generations. And then there's multiple community baby showers that are being held to improve safe sleep recommendations and get the education out there. Outside of the US, New Zealand has a pretty high rate of SUID in indigenous areas. They have the wahakura, I'm probably saying that wrong, which is the little basket on the left. It's woven, and this is helps break down some of the cultural barriers because it has been used in the past in historical times, and so the population is a little bit more receiving to it and open to it. Also, there's peppy pads or pods, and that is the little plastic box on the right. Those were dispersed during an earthquake, the Christchurch earthquakes, which they lost a lot of their cribs and places to place the baby, so they gave out those. The evidence is still pending, but there's some indication that there is a reduction for SUID in these areas. Looking at Finland, Finland has a governmental funded baby boxes that they've been giving out since 1938. They're given to every expecting mother that presents for prenatal care by the 4th month of pregnancy. They give out, basically it's a cardboard box, and they have a tightly fitted sheet, some clothing and supplies that are supposed to be good for the first 6 months of life. Also, it's used by a lot of parents there. It's portable, practical, and easily replaced. That sounds like a good idea. Ballot Health has caught on. We give out free baby boxes for all newborns in 6 of our hospitals, possibly transferring to 10 hospitals in the near future. These are flame-resistant baby boxes that include a tightly fitted mattress and cotton cover. It also has a small bag for diapers and other baby care products. These mothers who receive these boxes are required to watch several short online videos at the Baby Box University just for educational materials. So it's not just providing the environment for the baby to sleep, it's also educating the parents and caregivers. This also gives them access to over 7,000 videos regarding safe sleep and other anticipatory guidance. So I think it's a great idea, and we have some good local efforts going on. I have tons of references if anyone needs them. Does anyone have any questions? Yeah.
I was wondering if it looks, and I think it kind of just because of the nature of this type of research, that most of it's correlational in nature, right? The risk factors and protective factors. And do we have a sense of, like, kind of any of those that would be kind of grouped into causal factors that we know of? I mean, you were saying that that being on WIC was associated with having more unsafe sleep nights. And so in a sense, you could say being on WIC is a risk factor. We know that that's not really the core thing that's dangerous about it. So I didn't know kind of if there was any research about kind of are there any core factors related to multiple of these risk factors that might bring them together, or help us understand why there are such risk factors?
That's a really tricky question. I think correlating all of these different risk factors, I don't think you can really prove that there's a causation, but if you have a bunch of different risk factors, I think that's probably enough to say that those are probably what's causing and what can, if it's relative to SIDS, I think having multiple risk factors, we should try to decrease those, even if we can't say 100% this is causing it.
Well, it looked like it had that three aim or that 3-tier model of what is causing it. So it looked like some of those maybe would fit under some of those tiers. Like,
yeah, they definitely would. It's just there's not enough research on the pathogenesis to definitively say, yes, these are causing 100% and say that effectively.
Yeah, that's tough because in most of the cases it's unexplained, but if you look back at your huge slide with all the risk factors at the beginning and you try and classify those into modifiable and non-modifiable risks, it's still compounded quite a bit because we say, well, I've got a young mom, so that's a non-modifiable risk, but then if you look at, she had the other slide that showed that young moms are more likely to practice unsafe sleep practices, so more likely to do co-bedding and more likely to do and race is another non-modifiable risk factor, but a lot of that I think could be improved by educational tactics. So she's shown that strong positive education helps decrease some of those modifiable risk factors, and that probably would, I think, help some of those strictly non-modifiable risk factors. So myself and Dr. Shaw and Tara are on a local committee basically that reviews all child deaths regardless of cause, and these sleep-related deaths and unexplained infant deaths definitely happen around here at a higher rate than you think. And a lot of times, I did want to clarify one point, that the AAP specifically called out recliners in the recent recommendations. So they talked about recliners are a common spot where babies can, if mom or dad falls asleep while they're holding baby in the recliner, then that's just a huge risk for baby to kind of get down there and get, and that would be a suffocation related or a sleep related infant death. The AAP, that's where they kind of soften their sense a little bit on co-sleeping. So they did say if mom is breastfeeding and is starting to feel drowsy in the recliner, then it would be reasonable to move into the bed and breastfeed in the bed. So they didn't say that with dads though. Dad, if you're holding the baby, dad needs to put the baby down in its own place.
And non-parental caregivers.
Right, exactly, dad or other. So that's the ones that they softened a little bit on. If mom is actively breastfeeding, then it's better to be in the bed with mom than it is to be in a recliner with mom falling asleep.
Yes.
And I think, so when we have all those non-modifiable risk factors, that I think should just increase our educational efforts. And I agree 100%. We should be talking about this anticipatory guidance-wise with everybody. But especially if we see some of these red flags or risk factors, and that should maybe be, instead of just the list of things you talk about in your well child check, you got your baby to sleep on the back, right? That's good. Maybe you could spend a little bit more time on that. And we get to see these families a lot of times in the newborn nursery, in the NICU, in kind of rooming in environments, and in the peds floor as well. And I think that's a huge time that we can really focus our efforts on education. So I try to do, you talked about crib audits, I try to do that sometimes during rounds and just say, hey, use that as a key kind of teachable moment, I guess. I could go on for hours. I won't.
You mentioned the baby box, but you all also know that we have the grant for cribs for kids to give out. I've had several people ask me about that in the last week.
Yeah, we do.
So we have some, so check them out.
Thank you.